So heart failure, heart failure is a little bit different in terms of definition and approach from what we usually do. But the basic definition remains the same. Um, when we talk about heart failure, we refer to the inability of the heart to pump blood to meet the needs of the body. So the inefficiency of the heart, um, that's a broad definition of heart failure, inability of the heart to pump blood to meet the needs of the body. And we talk about you can have structural abnormality in the heart. So the heart can be malformed or a disruption in the structure, or it can be purely a functional impairment. So the heart might look physically normal, but the different parts are not functioning properly. So you have to sort of embrace that concept. So not because the heart structure looks normal, there can also be impairment in the heart function by different things, and we'll go into that. So you'll recognize that when we talk about heart failure presently, we talk about heart failure with reduced ejection fraction. So the common approach to heart failure is to divide it into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So if we go over what ejection fraction is, the ejection fraction is the percentage of blood that's pumped out of the heart. And we have all different formulas to derive the ejection fraction. Those of you who do echo, you know that it's the end diastolic volume minus the end systolic volume divided by the end diastolic volume. That's ejection fraction. So what I'm saying to you, 2017, when we talk about heart failure, is either heart failure with preserved ejection fraction, and we'll define that, and then you have heart failure with reduced ejection fraction, and we're going to define that as well. Okay, so we're not using the older term congestive heart failure. We're not using diastolic heart failure, that type of thing. We're not using those terminology. So a rough definition is when we talk about heart failure with reduced ejection fraction, we're talking about heart failure. The patient have signs and symptoms of heart failure, and the ejection fraction is less than 40%. So that's a broad definition, okay? So that is heart failure with reduced ejection fraction. And we usually refer to this as systolic heart failure. So the ejection fraction is less than 40%. And again, using using echocardiography, ejection fraction is the end diastolic volume minus end systolic volume divided by the end diastolic volume. And then when we talk about heart failure with preserved ejection fraction, then we're talking about ejection fraction greater than 50%. And you have the definition for ejection fraction, so you can work it out. So we used to call heart failure with preserved ejection fraction diastolic heart failure, but the proper term at this time is heart failure with preserved ejection fraction. And you need to know the ejection fraction that would define heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So it's important to note those distinctions. But this is a more comprehensive definition. So again, heart failure with reduced ejection fraction, the ejection fraction is less than or equal to 40%. And in the literature, you're going to see it's written like this: HF and a small r for reduced ejection fraction, and big, yeah. So in the literature, it will be written like this. So it is, again, it's referred to systolic heart failure. That's what we used to call it, systolic heart failure. All right. Um, and then heart failure with preserved ejection fraction is written like that: heart failure with a PEF. But the ejection fraction for heart failure with preserved ejection fraction is greater than or equal to 50%. Used to refer to as diastolic heart failure, and all that sort of thing. There's also what we call a borderline heart failure with preserved ejection fraction, borderline. Okay, heart failure with preserved ejection fraction improved. Okay, so if the patient presented first with heart failure with reduced ejection fraction, you treat them, and now it's greater than 40%, then you classify that group as heart failure with preserved ejection fraction improved. Don't get bogged down in these two terminologies. You need to concentrate on the first two: heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. You have to know the definition. So one with reduced ejection fraction less than or equal to 40%. So you have to know, because if your patient comes to you and you're treating them and they have an ejection fraction of 45%, that is not heart failure with reduced ejection fraction. So you have to know the definition. You have to be familiar with the definition. All right. Let's just look at some heart failure epidemiology, because heart failure is extremely important. You need to be able to make the diagnosis, and you also need to know the burden that heart failure have on the population. So those of you who are doing exams, heart failure increases with age. The older the older one get, the greater the heart failure. We're going to concentrate on heart failure with reduced ejection fraction in this lecture. And then we have another series of lectures that we're going to deal with heart failure with preserved ejection fraction. So we're going to separate them out. All right? So we're going to spend a little time with heart failure because it's so important. We're actually going to dedicate about 4 lectures to heart failure with reduced ejection fraction. And then for heart failure with preserved ejection fraction, we'll spend another couple of lectures, because it's very common, and you need to know to make you need to know how to make the diagnosis, how to treat these individuals, and it appears on all exams. So for people who are doing exams, you have to know the epidemiology. Both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction increases with age. However, for patients with heart failure with preserved ejection fraction, the increase with age is much greater. Okay, but the older you get, the greater your chance of getting heart failure. The lifetime risk of developing heart failure is 20%. Okay, so if you take 100 individuals and you follow them for their lifetime, 20% of them or 20 of them will have heart failure. And we talk about the risk factors for heart failure. And there are risk factors for heart failure. And the risk factors for heart failure: hypertension, diabetes mellitus, and obesity, the so-called metabolic syndrome. And you need to be familiar with the metabolic syndrome. Okay? So these are the risk factors. You're going to see, we now divide heart failure, well, we can grade heart failure. And it's important to know the risk factors when you're grading heart failure. Okay? So you're familiar with the New York Heart Association classification and Canadian classification, but there's also a grading system for heart failure, and that will appear in all exams, all level of exams. But you have to be familiar with the risk factors for heart failure. So if you have hypertension, diabetes, or you have the metabolic syndrome, you have a greater chance of developing heart failure. And the metabolic syndrome, if you have any three of the following: abdominal adiposity, a fat waistline, hypertriglyceridemia, high triglyceride level, low HDL cholesterol, hypertension, and fasting hyperglycemia. So if you have any three of this, then you have the metabolic syndrome. The importance of the metabolic syndrome: these individuals tend to have insulin resistance, and they develop atherosclerosis, of course, and will have problems with coronary artery disease. So any three of these 5 parameters will give you the metabolic syndrome, and it is one of the risk factors for heart failure with reduced ejection fraction. Continue with epidemiology. So heart failure free survival at age 45, if you have no risk factors for heart failure, no hypertension, no diabetes, no metabolic syndrome, then that's so you can live another 10.6 years without heart failure. If you're a man, if you're a woman, you can live another 14.9 years without heart failure if you're a woman. All right. So these are some numbers that is encouraging. About 5 million individuals in the United States have heart failure. So it's a tremendous burden. Okay, so 5.1 million clinically manifest heart failure in the United States. And if you look at the prevalence, it's greater in black male. It's about 4.5% of the population. Black females, about 3.8%. White males, 2.7%, and white females. So it's a greater burden in the African American population. Okay, males greater than females. Okay, but the total burden is about 5 million individuals in the United States that have heart failure. Lean individuals tend to have a shorter survival than obese individuals. So this is what we call the obesity paradox, because remember we said one of the risk factors for heart failure is obesity. But if you are obese and you develop heart failure, you live longer, as opposed to if you are skinny and you develop heart failure, you have a shorter survival. I'm not saying that individuals should go out and get obese, but it's the obesity paradox. So all right. So there's about 650,000 new cases annually. And at age 65 to 69, it's about 20 per 1,000 individuals that have heart failure. And as we said, it increases with age. So greater than age 85, about 80 per 1,000 will have heart failure. Okay? It's the older you get, the greater the heart failure burden, the greater the incidence of heart failure. What about mortality? So this is a deadly disease, okay? So approximately 50% of individuals within 5 years of diagnosis is dead, okay? So 50% mortality within 5 years of diagnosis. It's a fairly deadly disease, so it's important to make the diagnosis and treat these individuals adequately, because we have medications that can improve survival, reduce mortality. So you have to make the diagnosis and then treat them appropriately. The ARIC study, which means atherosclerosis risk in community, look at the case fatality after hospitalization. So that means the patient is hospitalized, what happened to them after they're hospitalized. So at 30 days, about 10.4% mortality. At 1 year, 22%. 5 year, 42.3%. So, basically what we're saying, within 5 years, half of these individuals will be dead. So it's important, again, to make the diagnosis in an expeditious manner as possible and treat them appropriately. We have good medications to treat them. So, all right. Now we come to the staging of heart failure. And people who are doing exams, they're gonna bring the stage because they expect you to know the stage of heart failure. I'm just gonna briefly say that stage A and B, these are individuals who have essentially no symptoms. So your stage A and your stage B are patients who have no symptoms. Stage C and D, these are symptomatic individuals. Okay? So if you look at the 5-year mortality breakdown in terms of stage, so stage A heart failure is an individual who has just risk factors for heart failure. And I went over the risk factors: diabetes, hypertension, and the metabolic syndrome, atherosclerosis, if you want to have that. That's your stage A. Your stage B, these are individuals with risk factors, but they also have structural heart disease. So the difference between your stage A and your stage B, your stage A have only risk factors. They have no structural heart disease. Whereas your stage B, they have risk factors and they have structural heart disease, but they have no symptoms. So both A and B have no symptoms. Stage C, these are the symptomatic patients. Stage D is what we call the refractory. Those are individuals who you have seen time in, time out. They live at the hospital. They constantly coming back. Okay? All right. So the epidemiology, people who are doing exams, epidemiology is, they're going to bring you, you're going to get a lot of questions on epidemiology. Remember, it's more of a burden in the African American population. So blacks have a higher risk of heart failure, and blacks have a higher, of a greater 5-year mortality rate from heart failure as well. All right. When we look at hospitalization in the United States, that is the primary diagnosis in over 1 million individuals annually in the United States. It's a primary diagnosis. And the 1-month readmission rate is about 25%. A quarter of these individuals are going to come back in another month. Okay? So it's a chronic disease, and you're going to get repeat offenders. The total costs in the United States exceed $30 billion annually. So it's a tremendous burden financially. Okay, total cost exceeds about $30 billion annually in the United States. And these are current data. Again, you need to know the stages of heart failure. For some of you, it's a relatively new concept, but it's very testable, and they're going to test you on it. So stage A heart failure, these are individuals at higher risk for heart failure. They have risk factors, but without structural heart disease or symptoms of heart failure. Okay? They are at higher risk for heart failure. They have risk factors then. So they will have the diabetes, they'll have the hypertension, they'll have the metabolic syndrome. But they have no structural heart disease, they have no symptoms. About 65 million individuals in the United States have stage A heart failure. Okay? 65 million per year have stage A heart failure. Stage B, these are individuals who have structural heart disease now, but without symptoms of heart failure. And that group is a little smaller, about 8 to 10 million per year in the United States. Stage B. Stage A and B are asymptomatic individuals. Stage A patients or individuals have no structural heart disease, no symptom. They have only risk factors. Whereas your stage B, they have structural heart disease without symptoms, and this is the total population. Your stage C, individuals have structural heart disease with prior or current symptoms of heart failure. So these are majority of the patients that you see in the hospital or in the office are stage C. So they have structural heart disease with prior or current symptoms of heart failure. About 5 million per year in the United States. And then stage D, I said refractory heart failure. These patients require specialized intervention. You know, we're going to go over this in one of the distant lectures. They may require left ventricular assist device. They may require intravenous inotropics. We'll go over. So they might, just a different type of intervention, specialized intervention, not something that you're going to find in your regular hospital. So these are your refractory heart failure patients, stage D. So if you look in the literature, they will just list them. So stage A, again, these are individuals at high risk for heart failure, but without structural heart disease or symptoms of heart failure. So these individuals have no symptoms. So on the left-hand side, we have the stage, and on the right-hand side, we have the New York Heart Association classification. So some of you might be familiar with the New York Heart Association classification. So again, those individuals who are doing exams should be familiar with the New York Heart Association classification and also the stage. So again, your stage B patients have structural heart disease, but without signs or symptoms of heart failure. And they would fall into the New York Heart Association Class 1. So your New York Heart Association Class 1 individuals, they have no limitation of physical activity. They can do whatever they want to do, and they have no problem. Ordinary physical activity does not cause symptoms in these patients. So your grade or your stage B patients will be classified as a New York Heart Association classification 1. So your stage C, these are individuals with structural heart disease now, with prior or current symptoms of heart failure. So remember, A and B have no symptoms. C and D are symptomatic. So your stage C can be either New York Heart Association Class 1, 2, or 3. Okay? So New York Heart Association Class 1, these individuals have no limitation of physical activity. Ordinary physical activity does not cause symptoms of heart failure. Okay? Your New York Heart Association Class 2, slight limitation of physical activity, just, not tremendous, just slight. They're comfortable at rest, but ordinary physical activity results in symptoms, shortness of breath or fatigue. Okay? That's your New York Heart Association Class 2. And then the New York Heart Association Class 3, individual have marked limitation of physical activity. They're comfortable at rest, but less than ordinary activity causes symptoms. So your stage C patients can be New York Heart Association Class 1, 2, 3, or even 4. That is, 4 is they're unable to carry on any physical activity without symptoms of heart failure or signs of or symptoms of heart failure at rest, or they may have heart failure at rest. So your stage C can have New York Heart Association Class 1, 2, 3, or 4. Your stage D, however, they live at Class 4, New York Heart Association Class 4. That is, they're unable to carry on any physical activity without symptoms of heart failure or symptoms of heart failure at rest. So you need to know your New York Heart Association classification, New York Heart Association functional classification, and you need to know the stages of heart failure. Patients doing individual doing exams need to know that. Okay. All right. So when we talk about the heart, the heart is a little bit different from other organs, and if the heart is insulted in any which way, it starts to remodel. Okay, so when we say insult, we talk if the patient suffers from a heart attack, a myocardial infarction. If patients have high blood pressure and the heart is subjected to this over time, so anything that insults the heart will cause remodeling. And so common insults includes myocardial infarction, okay? So heart attack or excessive load such as hypertension or even aortic stenosis or something like that. So once the heart is insulted, remodeling will occur. And when we talk about remodeling, we talk about myocyte loss. You're going to lose muscle cells, and the muscles become elongated, and you get what we call slippage. This results in dilatation of the LV and hypertrophy. So the heart muscle thickens. So it dilates and the muscle thickens. And this results in increase in diastolic wall stress. So again, once the heart is insulted, okay, and these are common insults to the heart, you get LV remodeling, myocyte loss, elongation, slippage, LV dilatation. So all the bad things that you see happening to the heart is as a result of remodeling. So you want to prevent insult to the heart. So when you have LV remodeling, you have decreased energy in the muscle, you have decreased LV reserve, and it results in heart failure. So you want to prevent the insult in majority of the cases. Sometimes you just can't do it, but you want to try and prevent insult. All right.
Hey guys,
This
are
is
you hearing me?
this is just a schema that sort of go over everything we've been talking about. Um, all right. So again, the initial insult to the heart.
Initial insult.
So, um, so you guys need to mute your computer. All right. So initial insult. So it could be myocardial or excessive load, hypertension, whatever you call it. Then you have remodeling. And we talk about myocyte loss, elongation, slippage, and that results in hypertrophy, LV dilatation. So, LV. So it's a vicious cycle, and you get diastolic wall stress, you have loss of energy, and then you get decreased LV reserve. That results in increased afterload, and then clinical syndrome of heart failure. So, insult, the initial events, insult, LV remodeling, and then heart failure. um, Again, so the cardiac insult eventually give rise to cardiac dysfunction. Okay, we're just looking at heart failure with reduced ejection fraction. So when we go into heart failure with preserved ejection fraction, then we'll look at some of the pathophysiology there. But again, cardiac insult will give rise to cardiac dysfunction. When the heart starts to fail, then there's a series of compensatory mechanisms that want the heart not to fail, okay? Try to preserve the body. It tries to maintain cardiac output and try to maintain blood pressure, okay? So insult, cardiac dysfunction, the compensatory mechanism that kicks in. And it tries to maintain the cardiac output and maintain blood pressure. So again, when you have cardiac insult and cardiac dysfunction, you get decreased stroke volume, which is the volume of blood that the heart pumps out per beat. And as a result, you get decreased cardiac output, okay? When you have heart failure, you get increase in the end diastolic pressure and volume, okay? You get ventricular dilatation and hypertrophy. And you get impaired filling, so-called diastolic dysfunction, and you get reduced ejection fraction or systolic dysfunction. So these are, the abnormal stuff that goes on inside the heart, and you can just trace it back to what what exactly is happening. So what happened to the vascular system? When the patient develops heart failure, you have increase in systemic vascular resistance, because again, the body is trying to maintain blood pressure, maintain cardiac output. So the vascular system, meaning the arterial system, tend to constrict, and you get increase in the systemic vascular resistance. You get decrease in arterial pressure, okay? You have impaired arterial pressure, you have impaired organ perfusion, because you're going to get decreased output from the heart, and as a result, you're going to get decreased blood flow to the organs. So you're going to get impaired organ perfusion. Organs such as the kidney, the liver, are very sensitive to decreased blood flow. So if the blood flow to these organs are decreased, then you develop other organ failure, and those are readily apparent. You also get decreased venous compliance and increased venous pressure. So these are this stuff that goes on in the vascular system. Again, one of the main compensatory mechanisms in the heart is the so-called Frank-Starling mechanism. And we did an extensive lecture on this. So this is a good time for you guys to review your Frank-Starling mechanism, when we did the determinants of cardiac performance, myocardial performance. We delve into the Frank-Starling mechanism. So when the heart fails, when you have a reduced ejection fraction, the increased stretch will result in increased output from the heart. And that holds true up to a certain point. So again, the Frank-Starling mechanism comes into play. Over time, however, because you're talking about a stretch and then contraction and ejection, you get chronic ventricular dilatation or hypertrophy and tachycardia. So these are our compensatory mechanisms. So if you see a patient who is untreated with heart failure, they'll be tachycardic, because they're trying to maintain the cardiac output and blood pressure. And of course, when you examine the heart, it will be enlarged. All right. So one of the nervous system that plays an important role in the compensator mechanism is autonomic nerves. So you tend to get increased sympathetic adrenergic activity, which increases the heart rate, and it attempts to increase the contractility as well. So you get increased sympathetic adrenergic activity. So this is an important compensator mechanism in heart failure with reduced ejection fraction. And again, these are very testable. So you're going to see they're going to give you all type of hormones, sympathetic adrenergic hormones, and ask you if that level is increasing heart failure. So yes, it is. So autonomic nerves increase sympathetic activity, and you get a decreased vagal activity to the heart. So remember, when the vagal activity slows the heart rate down, sympathetic activity increases the heart rate. So you're going to get an increase in sympathetic adrenergic activity to the heart. So a lot of these individuals, if they're untreated, the heart rate is going to be high. Okay, because of the increased sympathetic adrenergic activity and decreased vagal activity. Again, compensator mechanism, hormones. Because, as we mentioned, you get decreased perfusion, decreased cardiac output. The kidneys are very sensitive to this, and you get a stimulation of the renin, angiotensin, aldosterone system. So this system is revved up, okay? And these individuals will have increased aldosterone level, and they'll also have increased angiotensin 2 levels as well, okay? Or they'll also have increased vasopressin, which is an antidiuretic hormone, okay? They have increased circulating catecholamines, okay, and increased natriuretic peptides. So these are all compensatory phenomena that occurs inside the body to maintain cardiac output and blood pressure. Okay, the renin-angiotensin system, renin-angiotensin-aldosterone system, the vasopressin, that's the so-called antidiuretic hormone, circulating catecholamines, and the natriuretic peptides. So with your neurohormonal activation in heart failure with reduced ejection fraction, you're going to get increased norepinephrine level. It's one of your catecholamines. Okay, you'll get increased angiotensin 2, increased aldosterone level. So remember, we say you get an increase in your renin, angiotensin, aldosterone system, okay, and increased catecholamines. So if you were to sample the blood, you'll have increased norepinephrine level in these heart failure patients and increased angiotensin 2 and aldosterone. Short term, these are beneficial, but long term, they cause hypertrophy, apoptosis, which is programmed cell death, ischemia, arrhythmias, remodeling, fibrosis. So over a long period of time, they cause bad stuff. Okay? They will help the individuals short term, but long term, they're associated with the hypertrophy, thickening of the muscle, apoptosis, which is programmed cell death, so the cells will die, ischemia, which is reduced blood flow to the muscle, and arrhythmias, abnormal rhythm, remodeling, we went over remodeling, and fibrosis. So these are all the deadly stuff that will occur in the heart over time. So the compensator mechanism are bad news. They increase morbidity and mortality. Okay? All right, so we're going to stop here, and